Okay, I would like to speak to you in this video about Parkinson's disease and the drugs used to treat it. I believe this is video number 7 for the central nervous system. And we are going to introduce I'm going to give you some background information on Parkinson's. And then we're going to introduce some of the different anti-Parkinsonian agents, of which there's quite a few. What I'd like you to take out of this is an understanding of the neurotransmitters that are out of balance with Parkinson's disease, the two main ways in which drugs are used to treat this disorder, and then we're going to spend our time mostly focusing on one particular drug, and the mechanism of action of that particular drug of choice, but I'll run you through some of the other ones as well, other particular drugs and mechanisms as well. So a little background information on Parkinson's disease. It's the most common degenerative disease of the nervous system. It's actually the third most common neurologic disorder of older adults. The onset of the disease traditionally has been somewhere between ages 40 and 70, with a peak between 58 and 62 years of age. However, we're seeing more and more younger people, including teenagers, being diagnosed with Parkinson's disease. Men are affected 1.5 times more often than women, and once the diagnosis is made, the disease is progressive and there are no known cures currently. Drug therapy is not curative. It just slows the progression. There are really two types of Parkinson's disease. The most common is referred to as idiopathic, meaning there's no known cause. The other type of Parkinson's disease is secondary Parkinson's disease, which is secondary to another medical condition, most oftentimes something to do with the central nervous system, like head trauma, brain infection, brain tumors, etc. There's a pretty good body of evidence and growing all the time that neurotoxins are at play here. Probably the current thinking is that there's definitely some environmental factors that are definitely affecting the presentation of Parkinson's and this increase in diagnosis being made. There are drugs, the antipsychotic agents, which we haven't really talked about yet, but we will, are also oftentimes a frequent cause of secondary Parkinson's disease, or they are drugs that are used to treat, like schizophrenia, for example, and they cause, as a side effect, the Parkinsonian-like picture. The diagnosis of Parkinson's is fairly challenging to make with there not being a definitive diagnostic tool. The diagnosis is usually made based on clinical presentation, and the symptoms generally start fairly subtly. Probably the most common symptoms that people will report is a feeling of fatigue, and oftentimes they have some sort of motor abnormalities, most oftentimes reporting that they have seems like their movements are slowed or challenging. And oftentimes the first symptom is a tremor, which we'll talk a little bit more about. But like I said, there's no definitive tests for Parkinson's disease. So there are really 4 big signs of Parkinson's disease. Those signs are the tremor, muscle rigidity, bradykinesia, and postural instability. So I just want to talk about these for a minute. So when we talk about tremor, the tremor of Parkinson's disease is referred to as being a resting tremor. The tremor traditionally is seen in the hands or the head, and what you'll see is just a continuous motion or shaking when the patient is at rest, and that's why it's called a resting tremor. Kind of the classic presentation of the Parkinsonian tremor is what we refer to as a pill rolling or drum beating tremor. And with the pill rolling, it looks as if the patient is rolling a little pill between the first finger and the thumb, and they do that kind of repetitively. And the same kind of thing with the drum beating, as if they were beating the drumstick. And again, the thing to kind of pay attention to is that tremor is only evident at rest, which means when they're not doing something else. And that's kind of a classic presentation of the Parkinson's. Muscle rigidity is referring to resistance to passive movement of the arms and the legs. That's very common with Parkinson's, and the rigidity can initially look like stiffness or arthritis. Patients oftentimes have a difficult time bending over or moving their limbs. And we also see the rigidity extend to the facial muscles, and the rigidity presents as a lack of facial expression, and it's quite common. This can lead to difficulty chewing and swallowing, and uncontrollable drooling is also a pretty common presentation as the disease continues to progress. One other very noticeable symptom of Parkinson's disease is the lack of arm movement when a patient is walking. So in a normal situation, when someone's walking, their arms tend to swing from side to side. And in Parkinson's disease, the arms tend to be still when the patient is walking, and that's a pretty classic presentation. Bradykinesia refers to the slowness of voluntary movement and speech, which can be evident with chewing, swallowing, and speaking. Parkinson's patients have a very difficult time initiating movement and controlling fine muscle movements as well. Another kind of classic presentation with Parkinson's, along with the lack of arm movement when walking, they also tend to shuffle their feet when they're walking rather than taking normal strides. And the final sign of Parkinson's here is postural instability. And what that means is the patients oftentimes are stooped over. They can easily and frequently lose their balance and fall. So those are mostly motor symptoms that we've been talking about there with Parkinson's disease. There are other health problems that exist in more than 50% of patients. And the most classic one is clinical depression, which is not that uncommon with patients with chronic progressive neurological disorders. Whether it's the disorder or just depression around the diagnosis, it's really hard to say. Other pretty common issues with Parkinson's disease are anxiety, sleep disturbances, dementia, and disturbances of the autonomic nervous system, which can classically kind of be evident around the cardiovascular system, where they'll have oftentimes like hyper or hypotension, orthostatic hypotension, maybe increase or decrease heart rate. Those kinds of things are not uncommon with Parkinson's disease. So in terms of the actual disease pathology, we know that Parkinson's disease is caused by a lack of sufficient amounts of dopamine produced in the part of the brain called the substantia nigra. So there's a lot of neurotransmitter imbalances in specific regions of the brain that are particularly associated with Parkinson's disease. The two neurotransmitters we're going to focus on are dopamine and acetylcholine. What we know about the involuntary movements. Involuntary movements are controlled by the basal ganglia, which you can see on this slide here. The basal ganglia is kind of a region of the brain. It's actually just a couple distinct regions of the brain, which are connected together by neurons, or they're interconnected neurons. They're not directly connected, but they're interconnected in different distinct regions of the brain. The basal ganglia is responsible for the regulation of the flow of information from the cerebral cortex to the motor neurons in the spinal cord. This part of the brain helps to synchronize stopping and starting motor activity, which is a very big problem for Parkinson's patients. The two portions of the basal ganglia that are really important in the development of Parkinson's disease are the substantia nigra and the corpus striatum. The substantia nigra, let's see, here's a picture. The substantia nigra is a band of gray matter in the midbrain, and it's a major producer of dopamine. So we see a normal substantia nigra here. So it's a major producer of dopamine. Dopamine travels through axons along the nigrostriatal pathway to the corpus striatum. In the striatum, dopamine binds with receptors to produce a whole bunch of actions. One function that is important in the pathogenesis of Parkinson's disease is the planning and modulation of motor pathways responsible for unconscious movements. So in this capacity, when dopamine is present, it serves as an inhibitory function, slowing the flow of impulses down the spinal neurons. So when dopamine is present, the flow of motor impulses helps to produce coordinated, smooth, unconscious muscle movement. When the dopamine neurons are lost, what we see is a relative absence or a deficiency of dopamine in these particular regions of the brain, and symptoms of Parkinson's develop. Interestingly, it's not until 60 to 80% of the neurons lose their function, and subsequently the evidence is in the loss of dopamine available at the synapse. So it takes about 60 to 80% of those neurons to lose function before Parkinson's disease symptoms are starting to be observed. The other neurotransmitter that's important for us to pay some attention to is acetylcholine. Acetylcholine is found in the same location as dopamine. Now, there's not a whole lot of acetylcholine in the brain, but at this particular location, the substantia nigra, the basal ganglia and the substantia nigra via the corpus striatum, acetylcholine modulates the effect for neuronal outflow as well to the corpus striatum. But acetylcholine serves as an excitatory neurotransmitter at these locations. Under normal conditions, the excitatory action of acetylcholine is balanced by the inhibitory action of dopamine, and therefore smooth coordinated motion is able to be seen. However, when dopamine availability decreases, acetylcholine has a more dramatic stimulatory effect, and the abnormal muscle movements of Parkinson's are evident. When we, I forgot to put that up as I was talking. So the imbalance again is this acetylcholine and dopamine. Acetylcholine again is inhibitory at these locations, and dopamine is inhibitory at these locations, and acetylcholine is stimulatory. And normally they're in balance. So we see, the net effect of smooth and coordinated unconscious movement. However, as the levels of dopamine decrease with Parkinson's, what we see in terms of symptom presentation is what looks to be an over-exaggeration of acetylcholine. So the goal will be to, the goal will be to either increase dopamine or decrease acetylcholine. That's sort of the overarching goals of treatment for Parkinson's disease. It sounds to be quite easier than it actually is to achieve, So again, the goal is to restore the balance between dopamine and acetylcholine in these specific regions of the brain. So really there's two kind of main ways to go about this, and you can see this on the left. The sort of big groups of drugs are the dopamine agonists, and the anticholinergic drugs are the second big group. In our picture here you can kind of see, so there's lots of options for dopamine agonists, and the drug of choice, I'll start by saying, is this here combo of levodopa and carbidopa. I'll talk more in detail about this combination in a minute. But essentially what levodopa/carbidopa does is that, it shuttles dopamine into the brain, and it replaces dopamine at the synapse. The addition of carbidopa allows you to get more dopamine essentially into the brain. And I'll explain that to you in a minute. The other option would be to decrease the breakdown of the dopamine that's still there. So remember, they still have some dopamine. So the dopamine is broken down by enzymes and removed from the synapse. There's two enzymes at play. One is catecholamine transferase, or COMT. So by inhibiting that enzyme with a COMT inhibitor, that would reserve some dopamine in the synapse rather than breaking it down as quickly. The other enzyme that that breaks down dopamine or removes dopamine from the synapse at this location in the brain is a monoamine oxidase B enzyme, MAOB. So MAOB inhibitors are also used to potentiate the action of dopamine that's still available at the synapse. Another option would be to, what else do we want to talk about? Another option would be to give a drug that would increase the affinity of what dopamine that we have there to the receptor. So that would be a dopamine receptor agonist. That would be another option. If we can't get any more dopamine in there, then the other option is to try to reestablish our balance at a lower level by blocking the action of acetylcholine. So that's where the anticholinergic drugs come in there, specifically blocking the actions of the acetylcholine at the corpus striatum. There's not a whole lot of acetylcholine in the central nervous system, so that's an achievable action without causing too many horrendous side effects. All right, here's a summary picture for you to check out when you have a whole bunch of extra time on your hands. It sort of summarizes everything that we've been talking about, talking first about what's going on in terms of pathogenesis. So the neurons in that corpus striatal, the basoganglia corpus striatum or the nigrostriatal pathway are progressively injured. So we lose the dopamine containing neurons, seem to be injured at a much faster clip. So here's some of the symptoms that we talked about: the tremor of the hands, could be the pill rolling or drum beating tremor, resting tremor. The head is held forward, and oftentimes the whole body stoops forward because of the postural instability. They've got the facial muscles becoming more rigid. Their eyes tend to droop. They don't emote with their face. The mouth is oftentimes open, and as the disease progresses, there's a fair amount of drooling. Here's the gait that we talked about, the slow shuffling gait, and remember we also said the arms wouldn't move much when walking. So again, our drugs are going to be targeting increasing dopamine. Here, the dopamine receptor agonist, keeping the dopamine that we have there longer. That's where the COMT inhibitors and the MAOB inhibitors would work, which are not on our list here for some reason. And then the anticholinergics. So I really only want to talk about one drug with any detail, and that's the levodopa-carbidopa combination, which goes by the brand name Sinemet. So it's essentially almost dopamine. It gets across the blood-brain barrier, which is why we can't just give dopamine, because it's not orally effective or available. The problem with levodopa is you had to give a fair amount of it in order to get a little bit of it into the brain. And so the side effects that come with levodopa are mostly due to peripheral conversion of the levodopa to dopamine. So the abnormal movements of the body and the face, which look a lot like the Parkinsons itself. So jerking of the shoulder, the pelvis, the head, the grimacing, the drooling, etc. That is all, some of those are symptoms of Parkinson's, especially the head movements, the grimacing and the drooling. So that's kind of a challenge if they have a drug that, creates more movement abnormalities, which are especially initially some of the biggest some of the biggest problems for patients. There's also a lot of GI. Probably one of the things that limits the ability of a patient to take levodopa is the GI side effects. Mostly nausea is the big one. The cardiovascular symptoms are quite common, and that has to do with the sort of unstable autonomic nervous system. So they're kind of all over the place, up and down in terms of cardiovascular presentation, like we said before. And we might also actually see an aggravation of glaucoma, narrow angle glaucoma, if a patient has that. So the combination of adding carbidopa to the levodopa allowed us to give a little bit less hefty of a dose and still get the same amount of dopamine into the brain. So you don't have quite as much peripheral conversion, but you still get some. So I put some slides on here with lots of the other drugs, not because you need to memorize these, but because at some point you might want to refer back to these. So here's levodopa carbidopa, which we just talked about, Sinemet, or Parcoba is the other brand name of levodopa carbidopa. It's been around for a long time. In italics here we have the common side effects and then the less common but more serious side effects. And so a lot of these we've already sort of talked about with levodopa carbidopa. Then we have our dopamine agonists. So these are going to stimulate the dopamine receptors with the dopamine that's still there, right? So we're not giving more dopamine, we're just trying to potentiate the dopamine that they haven't lost yet. So some of these drugs may be familiar to you. They're used a lot. Parlodel, Mirapex, Requip are quite commonly used. Again, you can kind of see the common side effects in italics, and they're really focusing around, the autonomic dysfunction, still some GI stuff. Insomnia seems to be a big difference, or a big problem. Okay, so this one is sort of an interesting one. I just want to point out here because the route of administration is topical. It's a transdermal application, so a patch. So you can see there's lots of different options here. This one is a injectable as well. Here's our COMT inhibitors and our MAO-B inhibitors, and you can kind of look those over. We're not going to spend a lot of time, but I want you to know that they're available. This one's a weird drug. This is kind of an outlier. It's called amantadine, and it's an antiviral medication, and for some reason it seems to show, and I have no idea what the mechanism or why it works there, but it seems to show some efficacy in increasing acetylcholine. So it kind of acts like an anticholinergic in the substantia nigra. All right, so there's kind of a little bit of controversy. I'll put all this up and we'll sort of talk about it. So there's a lot of drugs. The one you want to focus on is the drug of choice is levodopa/carbidopa, one or the other of those. The issue with this is that the side effects are a big deal. There's a lot of side effects. So you can see like some of the strange ones like the amantadine and the anticholinergics seem to have less severe side effects, but they're also not quite as effective. One thing I do want to mention, which is a big problem, is this levodopa situation. And it appears that levodopa for every patient loses its effectiveness over a period of years. And it seems like 5 years is around the magic number. By 5 years or after 5 years, 75% or more of patients will have some kind of difficulty with the medication's effectiveness, side effects, or both, which essentially means the drug's no longer going to be clinically useful for them. And why that happens, nobody really knows. My feeling is it probably has something to do with the receptor density, downregulation of the receptors. I don't really know for sure, but that's what I'm guessing. It seems to make sense to me. So the controversy, I guess, is that how do you choose? Like, we have all these options. You've got lots of different, the best drug, without argument, is levodopa. However, you only have this sort of fairly short period of time, and then you use your best drug first. And so what happens after that drug wears off? So, this becomes it becomes a much more challenging conversation when you're, discussing this with maybe a 45-year-old patient versus a 75-year-old patient. I think most people would feel pretty comfortable if you have a 75-year-old patient that's had a pretty good life, and you make the diagnosis of Parkinson's disease, and they're not terribly affected currently, just starting to show symptoms, to say, oh yeah, you've got like 5 more years on levodopa where you're going to stay pretty good, right? It keeps them from progressing. So they're pretty physically and mentally active with the addition of levodopa, but knowing that it's going to only be about 5 years. And then you're not going to get that kind of an effect from some of the other drugs. And the other thing that's happening is they're continuing to lose neurons as those 5 years continue, right? So the other way to think about it is maybe go with something like an anticholinergic or a enzyme inhibitor like a COMT inhibitor or a MAO-B inhibitor, or even potentially a dopamine receptor agonist for a period of time, and try to keep the symptoms under control that way, keeping in mind that they are still losing neurons, and then reserving your levodopa for when the disease gets a little bit worse. So I only mention it because it is kind of a challenging situation, and there's lots of options, and in some cases giving the best drug first might not be the best way to go. So that is something that most of us will probably have to address in some way in our professional lives or personal lives. So I just wanted to sort of mention that. The last thing I want to introduce is something I found, some new research, which is kind of interesting. So what we've been talking about right now are these drugs that deal with the symptoms and really hopefully keep the disease from progressing too quickly, but they're definitely not curative or even restorative. However, there is a drug that's used for diabetes, actually, called exenatide, or Byetta is the brand name, and it falls under a relatively new class of drugs called the glucagon-like peptide 1s, or the GLP-1s. And these drugs are interesting. Their role in potentially neurodegeneration, Parkinson's, and maybe others as well, like Alzheimer's disease, potentially, is that they seem to prevent apoptosis and protect nerve cells from inflammation and oxidative stress. Inflammation and oxidative stress seems to be a big player in terms of neurodegeneration, and so at least in animal studies, these drugs have shown to be, in addition to being neuroprotective, also neurorestorative. So I think that the use of these agents may provide some promise and are worth kind of looking into. I put the link to a study for anyone who might be interested in this and looking for an extra credit assignment. You might go trying to chase down this research and read the report and see if it's something that interests you. If I remember correctly, it's a relatively small study. I want to say it was 35 or 45 patients. And it wasn't perfect in terms of design, but it's pretty good. And it does show some pretty interesting outcomes and maybe some potential promise. So that's my conversation with Parkinson's. I hope that was helpful. We're going to come back and we'll talk about analgesics in the next section. We've already talked about anesthetics, but analgesics is going to be the topic of the next video. See you then.